from UC Davis.
Well, thank you very much. I would also like to thank the organizers for the kind invitation to participate here today. It's really an honor to be in the presence of such great talent and so many great innovators. I am an interventional cardiologist by training and medical director of the Vascular Center, and I'm fortunate to work with a great team at UC Davis. I think we can't overestimate the importance of a great team and people that are willing to make the ultimate sacrifice for the team. This is our Institute for Regenerative Cures at UC Davis, which was opened a few years ago and directed by Dr. Jan Nolte, who many of you probably know, and she's been a great friend and collaborator over the past few years. On the clinical side, we have a great group in the UC Davis Vascular Center, a number of great research coordinators and nurses, my clinician colleagues in vascular surgery and cardiology, and a great team in the vascular laboratory, which is going to be so important for us in our upcoming clinical trials. The main focus of my disease team is unmet needs in peripheral vascular disease or peripheral arterial disease, which is a very prevalent condition, as you know, with the aging of our population and with the epidemic of diabetes mellitus. It's now estimated, conservatively estimated, that there's anywhere from 8 to 12 million Americans with peripheral artery disease. And in recent screening studies, anywhere from 20 to 25% of patients over 75 years of age have evidence of PAD. It's present in 1 of 3 diabetics over the age of 50 years. In particular, we're focused on critical limb ischemia, which is the most advanced form of PAD, resulting in breakdown of the skin, ulcers or gangrene, or pain in the foot, even at rest. These folks usually have very severe multi-level occlusive disease, and many have occlusive disease of all of their infrapopliteal arteries, which is very typical for diabetics who are at great risk for amputation because of this. So this is what a normal angiogram looks like from the knee down in the 3 major infrapopliteal arteries. This is a very typical angiogram of a patient with critical limb ischemia, one of my patients who had ischemic ulcers in the toes. Basically occlusion of all 3 of the infrapopliteal arteries and not enough flow through these collaterals to maintain perfusion to the foot and to allow for healing of these ischemic ulcers. So this is the face of critical limb ischemia, and you'll be happy to know that I left out the really gross photographs. Roughly, there are anywhere from 500 to 1,000 new cases every year per million people. 1 to 3% of the total number of patients with PAD at some point along the way will experience critical limb ischemia, with the main risk factors being diabetes and smoking, 2 problems for which we have no significant shortage here in the United States. Once the diagnosis is made, the 3-year limb loss rate is as high as 40% and much higher for those patients that cannot receive some form of revascularization. And when we fail in our therapies, this is what we end up with. In this case, on the left, a below-knee amputation, and on the right, the worst possible outcome, an above-knee amputation, where that patient is very unlikely to be able to walk again with the help of a prosthesis. Just a few amputation facts. Approximately 80,000 Americans undergo major lower extremity amputation every year due to vascular disease. As few as 25% will be able to walk outdoors afterwards. Only 50% or less will be able to return to work. And of those patients that have a major amputation, as many as 15% will require amputation of the other limb within 2 years, which starts that downward spiral towards premature death. What are the treatment options? Well, unfortunately, there's still a significant number of patients who receive primary amputation as their initial mode of treatment. We can talk about medical therapy, but there really are no good medical therapies for critical limb ischemia. And if patients cannot be revascularized, their likelihood of needing a major amputation is as high as 80%. So we perform endovascular therapies, angioplasty, stenting, and other therapies like that, surgical bypass in some cases. But for those patients that are not candidates for revascularization therapies, those are the folks that we're thinking about alternative therapies, such as gene therapies or cell-based therapies. The so-called therapeutic angiogenesis, where we're applying these therapies in patients with vascular disease to enhance new blood vessel development. As you know, there have been a number of candidate vascular growth factors identified over the years, and many have been studied in depth, including VEGF, FGF, HGF, and HIF-1 alpha. We are interested in VEGF, which we'll talk more about, and this has been studied in great depth dating back to the mid-1990s, where Jeff Isner and colleagues at Tufts University Medical Center looked at VEGF in patients with critical limb ischemia and demonstrated enhanced collateral formation and improvements in the ankle and toe brachial indices following the administration of intramuscular VEGF. This is an old slide, but it meant to highlight some of the initial trials and some of the initial enthusiasm with some of these factors in the phase 1 and 2 clinical trials. Unfortunately, these outcomes were not reproducible in the larger scale phase 3 trials. And so, I'm preaching to the choir here, but many of us have felt that cell-based therapies is going to be the optimal approach for these patients with a critical reduction in blood flow to their lower extremities. As you know, the predominant model here is the hind limb ischemia model, in this case showing immune deficient mice who have their femoral artery ligated and then decrease in perfusion to that limb, documented with laser Doppler testing. Jan Nolta in her laboratory, as have others, has demonstrated that infusion of marrow stem cells results in rapid delivery of these stem cells to the site of injury without hardly any uptake in the healthy leg. So these paramedic cells have the ability to home into the areas of great need, to arrive quickly, to start the reparative process and the process of new blood vessel growth. And as Jan has shown, that the transplantation of bone marrow stem cells augments the recovery of blood flow by day 7 in this mouse hind limb ischemia model. In this case, the greatest effect seen with these ALDH bright stem cells. This is a publication from the Journal of Vascular Surgery from 2012, showing a partial listing of some of the ongoing biologic therapy trials for critical limb ischemia. We are participating in the Biomet study using concentrated bone marrow aspirate, and the Cytomedics trial, which was described earlier, is not listed in this publication. What we're most excited about what we think is a very exciting and novel approach to this problem, which is basically bioengineering mesenchymal stem cells to produce angiogenic growth factor, in this case VEGF. And we're honored that CIRM had enough confidence in us to fund our research initiative in this area. And this is a 4-year grant, which will hopefully take us through phase 1, phase 2 clinical trials. Jan and others have demonstrated that MSCs can be engineered to secrete copious amounts of protein factors for delivery to other cells and tissues in the body, which is particularly relevant in the vascular disease space. Our development candidate is banked allogeneic mesenchymal stem cells, which are engineered to secrete VEGF-165A via the safety modified lentiviral vector. There are 2 important safety aspects here. One is that VEGF expression is under control of the responsive promoter, so that the growth factor will only be produced from MSCs in the recipient while they are taking doxycycline tablets. The vector also encodes the well-characterized suicide gene TK for additional biosafety. This gene allows eradication of all transduced cells if the antiviral ganciclovir is administered to these patients. Jan has demonstrated that these human MSCs engineered to produce VEGF significantly increase blood flow in this hind limb ischemia model as shown here compared to the non-engineered MSCs. And she has initiated the IND enabling studies for both safety and efficacy that will need to be done in this as part of this clinical research initiative. One of these is the product retention study as shown here, where the MSC VEGF cells were engineered to produce luciferase for imaging uses only. 100,000 cells per flank were then injected and imaged over time, and the study shows retention of at least 50% of the cells for the first week, but a log drop in cell number by day 14. And we know that we can enhance retention if necessary with glucose loading and ischemic preconditioning. So we hope to complete these IND enabling studies and have our pre-IND meetings with the FDA within the first year or two of this study and develop our clinical trial so that we will be ready to enroll patients in year 3 and 4 of the trial and complete on schedule with the great hope that we ultimately will be able to take this initiative into a phase 3 clinical trial and greatly help these patients in desperate need. This clinical trial will be similar to other trials in this space, basically involving no option CLR patients, basically patients that are not candidates for angioplasty or surgical revascularization therapies. It will be a dose escalation study. The first group of patients will be treated with unmodified MSCs, and then we will start with 50, then 100, 150 million cells of modified MSCs. It will be via intramuscular injection with angiosome-directed therapy, while at the same time we will be partnering with a group in Andalusia, Spain, where they will be performing intraarterial injection of these genetically modified cells. The primary efficacy endpoint of this initiative will be freedom from major amputation. We will be looking for important additional evidence of a response or signal via wound healing and the typical non-invasive measures of increased perfusion, ABI, TBI, pulse volume recordings, and transcutaneous oxygen measurements, as well as tissue perfusion pressure via laser Doppler sampling. And we will perform angiograms in all these patients looking for increased collateral formation. So in summary, we think that MSCs engineered to produce VEGF is a very exciting and promising approach to therapeutic angiogenesis. And we think there is also a very great unmet clinical need, as shown here today, to reduce the number of unnecessary amputations in diabetics and patients with critical limb ischemia. But obviously there's much work to be done, and we have about 4 years to do it in. And the last thing I'll say is, let's go Giants. Thank you very much.